Hi, everybody. It's Amy Jaramillo. I think we are probably ready to start. We already have a number of folks that are joining. Let me first just tell you the objective of this Zoom call. I think we take about an hour. My goal is to spend about a half hour going through the new things that we've been working with, the kinds of results that we're seeing, and kind of give a broad overview of what we're doing and why we're doing it. And then let me hand the call over after that to answer any questions. I like the idea of having kind of a live question and answer. I think it's easier for people to get the questions that they have addressed by comparison to emails or texts. Instead, this gives us a forum really for you to be able to ask whatever you want. I'll do my best to answer them. And anything that we don't get to on this Zoom or anything that just can't be answered this time around, we can always do some follow-up with. So, all right. So the disclaimer that I put right up front, a couple of things. Number one, I am not a physician, right? My focus is science. I am the strategist here at Body Science. My role is to figure out underlying causes, come up with a strategy, and work with the medical team to go ahead and implement that. The couple of other things that you should know. So from that, this is not medical advice. The other thing that you should know is always go to your own physician and ask them before you start doing anything. And then the other thing that I want to make clear, I think it's already known, but it's important to understand. The FDA has labeling in the world of motor neuron disease for two prescription medications, Radicava and Riluzole. Anything outside of that is non-FDA approved. And so the things that we're talking about today, although there is strong evidence through clinical trials and reports discussing their improvements or the reason for these therapies, it does not make these FDA approved. All right, so the summary. Number one, I am not a physician. Number two, this is not medical advice. Number three, always go to your own clinical team to get the advice of what you're going to do next. And then lastly, just remember, these are not FDA approved medications or therapies. Our center really is different than others. We are science first. And so routinely I'm asked, how are we getting the kind of results that we're getting in motor neuron disease? What I would tell you, we are really not trying to reinvent the wheel. I think this disease is too aggressive and too fast moving for us to try and figure out on our own as a clinic what are our best options. Instead, keep in mind, state of Florida has a Right to Try Act. There are certain requirements that have to be met. If we're looking at something that's currently in clinical trials, it has to have passed phase 1, which is safety. Phase 2, meeting a requirement for efficacy. So is it safe and does it work at some dosing? Phase 3 is a little bit different. That's when you modify dosing and find the best outcomes. And so from an option standpoint, as any medical center, always, if there is a medication for a different use, it can be used off-label if the medical team feels it's appropriate and safe. If something does not have an off-label use, but it's going through clinical trials, it may qualify for a right to try if, number one, the individual that you're treating has a condition that meets the right to try criteria. ALS, because of its aggressive degenerative nature, does. So if there was one good thing about having this, if there is such a thing, the fact that you qualify for that category. And then again, separate from that, if it's already gone through phase 2. And so scientifically, my role, understanding the difference between one person's cause of their motor neuron damage versus somebody else's, using tests to kind of delineate that and understand priorities, and scientifically really map out a strategy. And I think, again, that's what's led to the folks that we have had that have met criteria for reversal, and the folks that we have, meaning they've regained function. And as well, the folks that we've had that may not have regained function back to the point that they were prior to developing motor neuron damage, but they've either stopped progressing, slowed progression substantially or started to have limited improvements. All right. So I think it's about science. Again, I don't think it's trying to reinvent the wheel and coming up with the latest and the greatest. I think there's a lot of ideas that have already become very useful, but oftentimes just don't see their way into use in spite of meeting criteria, meaning they're safe and they've shown some efficacy. And so I think really what we're good at, number one, wrapping the right protocol around the right person, looking and figuring out why you have motor neuron disease and what our approach would be. And then second to that, using combinations of things. So it's already been made very clear it is unlikely a monotherapy is ever going to treat this disease. Okay, so meaning it's not like one medication is going to resolve the kinds of cellular dysfunction that occurs in people that have damage to their motor neurons. And so really the question becomes, what's the right stack or combination for that individual? And that's not an uncommon approach in medicine. Lyme disease comes to my mind, not because of potential relationship or relevance with motor neuron involvement, but just because anybody that's treated for Lyme can relate to the number of medications, the cycling of multiple different medications, the combinations oftentimes of medications from multiple different families, antibiotics with antifungals, with antivirals, with anti-inflammatories. And so I think when we're talking about real significant cellular dysfunction, we're not looking for a single medicine to do a magic trick. And I personally believe that's one of the reasons that clinical trials have such a high failure rate, because you're looking at one thing to see whether it can fix the cause and then repair all the damage and then restore all the cellular function. What kind of medicine could possibly do that? What class of medication could really do all the things that you would need to restore cellular health? And so for us, it comes down to what's the combination and does it match that person? All right. So then with that, to what I consider to be indisputable facts specific to motor neuron disease and ALS. Number one, and I think you've all heard me say this, I don't see this as a disease. And the reason I would tell you that a disease is something you look at somebody, you see their group of symptoms, the next person has the same thing, they have the same group of symptoms, right? So a disease has a degree of uniformity. Heterogeneity, by comparison, is the term that's commonly used in the world of motor neuron disease. And heterogeneity is, as it sounds, people look very different in spite of all having motor neurons that are not functioning properly. And so the question is not, can we treat or can you find an approach for ALS? I don't know how you would or could, right? Because ALS is not really the disease, it's the outcome. It's the result of whatever is now causing motor neurons to become dysfunctional. And then the symptoms that you have are classified into different degrees of motor neuron damage or motor neuron disruption. It doesn't change the fact this is a symptom. And so root cause analysis, that strategy for me becomes kind of the guiding principle. Thing number two, back in November 2021, there was a lot of discussion, a lot of fanfare that came with the clinical findings from the University of Tel Aviv that, number one, identified TDP43, that transcription protein, as not just a hallmark of the disease, but a primary cause of motor neuron synapse failure, an inability of the motor neuron to transmit a signal from one neuron to the next. And as well, they were able to show that breaking down that misfolded protein, the proteinopathy, allowed the neuron to go back to firing. So, I mean, that came with the fanfare and kind of the statement of, hey, this disease is reversible. Most recently, I understand Dr. Bedlack made a similar statement. I personally have not seen it, but I know a number of folks that have told me already. I'm glad. We're always looking for more and more consensus among the large institutions kind of to get on board with the fact that this disease looks to be treatable and reversible. that looks to be based on a lot of the new data, as well as the sheer number of documented reversals at this time. So for me, looking at this through the lens of a symptom rather than a disease makes it a lot more manageable. If you're trying to treat it as a disease, it's as if you have no starting point. You don't know what you're treating or how to treat it. Okay, but when you actually take it apart into its kind of composite pieces, what number of infections, what amount of chemical exposures, what amount of fungal overgrowth. When you see it in its individual pieces and then you treat strategically in a specific order, it gives you a starting point, it gives you an ending point on the clinical side, it gives you a roadmap, and that becomes important. And then again, starting from the position, understanding from the get-go, this looks to be a treatable disease. The number of reversals prove the reversibility. And so I don't think we're really in a situation any longer where either of those two, I'm going to call them facts, are in dispute. Right, we know at this point that this disease is treatable and reversible. Talking about the kinds of technologies that we put in and what happened this week, we started transcranial magnetic stimulation on the motor strip. And so once I put that out there in a post, just letting everybody know where we are, it brought up a lot of questions. And that was the reason I thought having a Zoom call today and going through questions and answers would be useful. With that in mind, let me just tell you how I got started with the idea, not just of transcranial magnetic stimulation or the astrocyte protocol, but kind of an overall change. There was a point about a year and a half ago where my focus was almost exclusively pathogen eradication. Can we see the bug? Can we kill the bug? So is it Lyme? Can we kill it? Is it herpes viruses? Can we kill it? Is it Coxsackie? Is it mycoplasma? We know the infections that can predispose individuals to motor neuron damage. We paired that up with certain chemicals that increase the veracity of those infections, and then as well looked at the genetics of that individual, and then kind of came up with a picture. We treated those infections. We were able to get substantial improvement. So when we looked at both antigen and antibody levels, we saw substantial improvement. And still with that, it was a hit or miss on who was going to show clinical improvement, meaning we had some people that had really impressive reduction in pathogen load from a lab point of view, but did not have improvement in their disease state. And so the question is, what are we missing? And I would tell you, as a center, just know, please, if nothing else comes out of this call, we are trying so hard to get this thing taken care of. I can't even imagine what it's like to live with motor neuron disease. And so truly, we really are trying to work as fast as we can, just understanding the dynamics of this thing. And the way that we get there is doing what feels logical. We can see the infections, we treat the infections. For the folks that see improvement, we're done. For the ones that don't, that means a deeper dive into the complexity of what's going on. And so Northwestern has been doing a lot of research on the mitochondrial health. It's been clear for a long time that mitochondrial dysfunction is at the heart of this disease. So there are multiple organelles in the cell that become dysfunctional, but the mitochondria is certainly implicated as one of the primary. And just as a reminder, it's making energy for the cell. So you think about the motor neuron. I mean, it's driving motor function. However much energy you imagine it takes to move things around a body, I mean, you're looking at that amount of electrical impulse that cell must be able to produce in its synapse. And so the number of mitochondria in a motor neuron and the health and efficiency of those mitochondria, when they are optimal, you expect motor function is as well. When those power sources are not working well, then you're going to see, of course, a decline in the ability of those motor neurons to create motor functions. And so Northwestern, I think, kind of pioneered the electron microscopy of the mitochondria to really pinpoint the damage. So that's to say, these folks looked under an electron microscope so you can get really, really close-up precision. And they were able to clearly show the degree of damage in the mitochondria. And so they publish and show their findings of what mitochondria look like in people with motor neuron disease by comparison to folks that do not have motor neuron disease. And I think that for everybody just clarified even further the role of mitochondria. What I was doing at that time was looking to eradicate pathogens, and I was trying to figure out how to repair the mitochondria in the motor neuron. What made sense to me a year and a half ago, the motor neuron does not have sufficient mitochondrial output. That was clear. Let me try and repair mitochondria as a whole. Let me use things that have been shown to improve mitochondrial function. On the medication side, things like methylene blue probably come to mind for you right away, but there's a lot of other things as well. And the way I looked at it was these mitochondria, we know that they're damaged, right? Northwestern already showed that through their electron microscopy and their findings. I thought that they were damaged or becoming damaged in the motor neuron. And so the motor neuron was my target. And I don't like the acronym ALS. I'm not afraid of it. I have a healthy fear, mind you, but the reason I don't use it is not because I think it strikes fear. The reason I don't use it is because I think it gives everybody on the clinical side a reason to just step away. Like, hey guys, there's nothing for us to do here. This person has this diagnosis. And so I find ALS is a label that I just don't like for all the reasons. The fact that it doesn't allow for good insurance coverage, the fact that nobody ever wants to do anything with you again as far as treating. It doesn't matter what other condition you have. Nobody else wants to see it. So I moved to the idea of motor neuron disease. And ALS, of course, is one motor neuron disease, one of many. The problem with that is by calling it motor neuron disease, it's like I constantly reinforce in my own mind that this thing is happening exclusively in the motor neuron. Now, I already know that that's not true because you think about the mood changes or pseudobulbar affect, right, that can occur. You think about the sensory involvement, so people that feel burning, tingling, numbness, the sense of ants or electricity, so sensory. So we know this is not just motor neurons, but still, because ALS for me was not a comfortable acronym, motor neuron became something that felt more reasonable. But by calling it that for all these years, again, I just kept reinforcing in my mind this is motor neuron disease. And so when I was looking for damaged mitochondria, I was looking for them in the motor neurons. And because Northwestern had already shown those mitochondria, that confirmed even further for me that I was looking at a target that was a motor neuron, except it wasn't a motor neuron target. And so this last summer, around July, August, I changed the approach that we had from motor neurons to the supporting network surrounding motor neurons. And it was at that point that I got clear on the fact that the supporting cells as a group or as a family, they are referred to as Galil cells. Okay. In that supporting network, so I've used this analogy a couple of times now, somebody that's driving a race car and the pit crew, right? The race car cannot continue racing unless the pit crew changes the tires and checks the engine, and I don't even know what else pit crews do. But here's the long and short. The motor neurons have their own pit crew. They work very hard and synapse very aggressively. They can become infected. They can become damaged. They need a new supply of engines. Okay, so no differently than that race car driver. Could be the greatest race car driver ever. It could be the greatest car ever. If you need new tires after 3 times around a track and you don't have a pit crew, I mean, you're not going anywhere. The Galil cells are essentially, in my mind, the pit crew for the motor neurons. Oligodendrites, microglial cells, and astrocytes become the 3 that are the most important. And because we were just talking about mitochondria, it brings up astrocytes. So astrocytes are not neurons, right? They're non-neuronal, and that's true for all the glial cells. Just like the pit crew, nobody in the pit crew has a car, right? They're repairing the car. So the pit crew over here, the glial cells, astrocytes have a very specific responsibility. a group of responsibilities. Number one, they provide a large majority of mitochondria to the motor neurons. So this is not motor neurons making a bunch of their own mitochondria. And so the point of failure, right, you got to leave room for the fact the point of failure of mitochondria and the damage may not occur in the motor neuron. Instead, the mitochondria moving into the motor neuron may already be damaged. Again, the area or the non-neuron tissue in the brain or cell in the brain that's providing the mitochondria to the motor neuron, that is largely a responsibility of the astrocyte. Mitochondria, they're calcium gated, so their charge is based on calcium, which is a 2+ ion. The question is, so even if they have mitochondria, where does the calcium come from? Astrocytes, right? So it's not to say motor neurons can't make calcium to voltage gate their mitochondria, but the mitochondria, the majority or a significant amount of calcium and even antioxidants are coming from astrocytes. So again, if you would have asked me about a year and a half ago, what do I think this is? I would tell you it's a motor neuron disease. And at that point, we had more of a hit or miss track record with improvements. What I switched to was the fact that glial cells are playing an important role. And microglial cells, as an example, so other than astrocytes, microglials, they're treating infections and repairing damage in motor neurons. Right? So each of these glial cells, oligodendrites, right, are creating the myelin for they're wrapping around the axon to preserve the electrical impulse. So you can kind of get a sense of the fact that the motor neuron, without the ability to get more mitochondria, the calcium to turn the mitochondria on and to get electrical impulses down the axon, to get antioxidants, right? The microglia to be able to repair damage and reduce infections, the oligodendrocyte to be able to provide the insulation for that electrical impulse. If those non-neuron cells are sick, then the motor neuron is not going to work well. Okay, so astrocytes for me became a really big priority. The personality switch from good to bad is an interesting fact. It's the idea that the roles as I've just described them, that's what those cells should do, the non-neurons, the glial cells, and that's what they do in folks that do not have substantial inflammation, infections, chemicals in the central nervous system, but they do have a Dr. Jekyll, Mr. Hyde kind of personality, meaning that although they should provide care, maintenance, and reduce inflammation for motor neurons, when they become sick, they do the opposite and they become pro-inflammatory. And so in a condition that's neurodegenerative, ALS being one of them, Parkinson's, Alzheimer's, these group of non-neurons, these glial cells, oftentimes are a contributor to inflammation. And so getting them healthy, getting them repaired, and getting them to do their job becomes critical. So you can kind of see on my side, again, moving away from the idea of targeting motor neurons to instead targeting the glial cells. And I am open for ideas. I don't know what the heck to call this disease. If we're not going to call it ALS and we're not going to call it motor neuron disease, what the heck are we going to call it? So we could have a contest and see who comes up with the best. But again, this is not really a motor neuron issue. And the way that we know it is by switching our approach away from a targeted motor neuron strategy and to a glial plus motor neuron strategy. That's where we've really been seeing a lot more of our improvements and in a much faster period of time. Okay, a parallel track with serotonin. So around the same time that I was looking for the real target or the mitochondria being supplied to the motor neurons is the same period of time that more and more data was coming out regarding the role of serotonin in motor neuron disease. We had already, up to that point, been aware of it, and we had tried multiple strategies to secure serotonin. So what is known in motor neuron disease, when serotonin levels are adequate or robust, progression is slower, speech, breathing, swallowing is less affected. Okay, so that part has been known for quite some time. Nudexa being a serotonergic medication. Imagine what it commonly does. It is designed to help improve pseudobulbar. You'd expect that, right? Improve emotion or mood control. But the fact that it also can improve speaking, swallowing, and breathing, so meaning serotonin is tied to those, is an interesting fact. And there's been a lot of dollars, so grants, recently being targeted at serotonin. Here's the thing: we already looked at it. We tried it as far as supporting serotonin and could not see improvements. Methylene blue is serotonergic, and it can improve mitochondria. So now that we're talking about serotonin, mitochondrial dysfunction, a lot of you have an understanding of why at the center we use methylene blue, but again, hit or miss. Lots of folks where I didn't see the improvement that we were looking for in spite of going after these two targets. All right, on the serotonin side, what we found, and the astrocytes play a role in this, it's not about increasing serotonin. It's about decreasing fight or flight, meaning the opposite of happiness, the opposite of serotonin is not necessarily sadness and depression. It turns out that the opposite of happiness is fight or flight. And so that is an acetylcholine personality, or that fight or flight is controlled by the neurotransmitter acetylcholine. And so the question, if we can't get the improvements that we're looking for by increasing serotonin, could we then just pivot and get the improvements that we're looking for by removing the switch that's holding serotonin down, right? And that is an acetylcholine pathway. Not to say acetylcholine is the only thing, but I would tell you there is a very definite link, and we know it now because we've already signaled that on, and we can see the changes and the improvements, and we'll talk about that more. An interesting note about serotonin and herpes simplex too. It's funny just looking at the infections. Remember, our starting point is always understand root cause and go after that. If we try and correct pathways, whether it's a serotonergic pathway or an astrocyte signaling pathway, but there are still infections or chemicals causing damage, you would not expect to get better or to stay better, right? And so step one is always identify and address underlying causes. But just because the underlying cause has been addressed or is improving, the titer level of an infection is going down, still does not mean that the cell will regain function. And so there is a point in time where putting systems or pathways back in place becomes as important or even more important than pathogen or infection eradication. Herpes simplex 2 gives you a pretty good example. Herpes simplex 2 is a common infection, estimated in about 70 to 90% of the human population. It lives in a cell body where the central nervous system transitions to the peripheral. So to say this differently, its favorite neighborhood, not exclusively, but almost exclusively, base of the spine, right? So kind of the area at the bottom of the spine. It's going to affect the spinal cord as it feeds into hips and legs. It is going to be involved with the nerves in the spinal cord that innervate the genitalia. It's why it can create lesions or sores on the genitals, right? That's why herpes simplex 2, not in everybody, but in about 40 to 50% of people that have herpes simplex 2 have lesions or sores on their genitals. When the infection reactivates, keep in mind, a large majority of people have herpes simplex 2 and never have those genital sores. Here's an interesting concept, just tying together the spinal cord and infections that are living down there and the brain. Herpes simplex 2 spreads primarily through intercourse, right? Through reproductive contact. And so you got to wonder, how is it controlling that? It's going to have some control over its host's willingness or desire to reproduce, right? If the only way that you spread is through sexual or intimate contact, and you can't get the host body that you're living in to want to have that type of contact, how are you going to spread? So interestingly, herpes simplex 2, although it lives in the base of the spine, it very definitely has control switches in the brain, serotonin and dopamine. It can and has been shown to increase the level of serotonin and dopamine, especially in dopamine being the reward center, right? Especially in relationship to sex or intercourse, right? It can, herpes simplex 2 can modify brain chemistry in a way to make the act of intercourse or the act of having sex become more pleasurable by increasing things like serotonin and dopamine. Here's the reason I'm telling you this. These are not just dumb bugs living in a body. These are bugs, viruses, bacterial infections, fungal infections. So whether we're talking about Lyme or Coxsackie, or whether we're talking about mycoplasma, whether we're talking about herpetics, we're talking about infections that are controlling actions, and they're modifying DNA. And so they're doing things that tie together serotonin and serotonin levels, right? Either for higher levels or for lower levels. And of course, downstream, those things are affecting progression. Speech swallowing. So once we started targeting serotonin, again, not by increasing serotonin, but by controlling acetylcholine pathways, we expected we were going to see better speech, swallowing, and breathing. We've had a lot of people doing videos. The way that we handle testimonials, again, this is not FDA approved. We're not a center that's going to make claims. We are not trying to make claims. We have no right to make claims, right? So in order to make claims, you're talking about a center that's gone through clinical trials, has proven evidence and FDA support behind it. Instead, on our side, we're going to use things that work, and we're not going to make claims because we can't. Instead, commonly, the folks that come on over here are going to put videos together to increase awareness of the treatability of this disease. The number of people that have put out videos over the course of the last 6 months showing improvement, speech, swallowing, and breathing is staggering. And the amount of improvement in speech, swallowing, and breathing has been very, very remarkable. What I would not have expected, I wouldn't have expected so much improvement in fine motor coordination. So most everybody has described better use of their hands. I would not have expected better limb function. So better use of arms, better use of legs. The video that was posted on Monday, so that was Sterling's video, being able to stand up better, having better coordination, clearer focus, clearer concentration. So what we expected by regulating acetylcholine was speech, swallowing, and breathing. We know that's a serotonergic pathway in relationship to motor neuron disease. The fact that we have seen so many other functional improvements in just mobility was unexpected. Again, we already tried serotonergic approaches. So for anybody that's out there that's thinking, let me try an antidepressant that will control the reuptake of serotonin, allow it to stay in the cleft longer, or try and dump more serotonin in. It's already been tried. I don't think it works. It doesn't mean that people would not benefit from an antidepressant if they're not depressed. It's a conversation to have with your doctor. But it does mean we did not find that just boosting serotonin with serotonergics like Nuedexta, methylene blue, SSRIs, SNRI, antidepressants, we did not find that worked. So we know serotonin is the key to improvements, but just boosting that level does not look to offset the acetylcholine and the fight or flight that looks to have linked itself to progression. Red light therapy, mitochondrial support. Again, we tried all those things and didn't find that they were going to be effective. And so now let's kind of switch gears into where we've transitioned to, which is not just medication, but therapies or technologies to start controlling neurotransmitters. Going back to the fact that I posted earlier in the week that we did our first transcranial magnetic stimulation, it kind of falls more into that area. Okay, so where is this whole thing coming from? the idea of transcranial or a modified type of neural therapy block, it's coming from the fact that we know this is not a location, it's not a nuclei or single point in the brain or even single type of neuron in the brain. It's a pathway being controlled by certain neurotransmitters. Now, I recognize this is much more complicated. So we could go into a full conversation at another time about the glutaminergic toxicity and the glutaminergic neurons versus the GABAminergic. I'm not trying to get us mired in the specifics and the science. And so just from a kind of a generality, here's what we know. There isn't a single location in the brain. There's not one place that's controlling breathing, but also speech and swallowing and movement and mood, right? Instead, we're not trying to fix on a location. We're trying to correct a pathway and a sequence of neurotransmitters, GABA and glutamine being some of them as well. Right, acetylcholine and serotonin. So we're trying to put that signaling through those neurotransmitters back into place. And we find is that's not really a medication, or at least I don't know of a single medication that can start to reorganize pathways for multiple neurotransmitters that are involved in motor neuron damage. And not just motor neuron, but neurodegenerative changes. So again, Alzheimer's, Parkinson's, and ALS. We have found that we have found modalities for all three of those conditions, right? And so again, keep in mind, it's not a single medication. And so we're going to start pairing it up with technologies. So my background, I spent about 10 years in neurogenetics. For the purpose of this conversation, it's irrelevant. What I think is useful is to know that I spent about 9 years in an area of brain stimulation. And so having been in a very large number of neurosurgical cases, one of my areas of expertise, anatomical localization in the brain for the different nuclei, looking at MRIs, fusing them with CTs, helping to identify targets, helping to reach those targets, helping to stimulate those targets and a deep brain stimulation context. And so the idea of transcranial, meaning not going and making a burr hole and driving a lead in, but instead going above the skull, right, with electricity and targeting certain areas. It's something for me that I already have a lot of experience with, a lot of comfort with. And so neuroanatomy for me is something that's very comfortable. It's a place that I have spent a lot of time in. And so it's one of the reasons that the idea of localizing a target and then trying to recruit from an electrical standpoint functionality becomes for me comfortable. Just know when we're doing it here in the office, I like to work with neurology for that. What we're looking to do is plot out the specific location, and it's different from one person to the next. And the way that you know that size of shape of a skull, right? So the measurement that you would use for somebody that is, I don't know, 6 foot tall is very different than for somebody that is 5 foot tall, is very different for somebody that has kind of an oval face versus a more squared face. So we work with a neurologist who helps with this kind of targeting, just to kind of get an idea. Adding technologies along with medication. So I alluded to that fact already. I don't think we're going to get to where we need to get to with just medication. And so the vagus nerve for me becomes a very, very important target. It is, in a most basic summary, a location where fight or flight is transmitted from the brain thinking it into the rest of the body that's going to feel it, with a heart rate that elevates, with saliva changes, with the fact that the stomach isn't hungry anymore. And so being able to control that signal at the level of the vagus nerve becomes very important. Now, what I would tell you is it's not one therapy, right? It's not transcranial. It's not a modified block at a stellate location. It's not the IVs that we're using to increase mitochondria and astrocytes. It's the combination. So just unpacking that for a minute. There is not a test that I'm aware of to prove that we are building mitochondria. However, the things that we are using have already been shown to improve mitochondria, specifically in astrocytes. Okay, so just know I don't have a numerical way to prove that that's what we're doing. Okay, however, we have already tried doing the individual technologies without the IV medication combinations, and they don't work. And when they do work, they don't last. So the couple of things, and I think I probably have that slide over here. Hang on, it's backwards. Okay, I'm gonna still go over it, even though I know there's a slide coming up, the long and short. We already knew that it was the medications, the IV therapies that we were using that was really allowing for the pathophysiology corrections to occur. And then the next question was on the acetylcholine, how do we know it's acetylcholine? And so we had somebody who had very substantial improvements in his voice. And so very substantial volume increases, the cadence or the speed of the speech increased, being able to say words that he was not able to say before, striking consonants. So there was no mistaking the very substantial improvements in voice. And then the question, if this really is an acetylcholine pathway, then we should be able to put in a medication that is a competitive binder at the acetylcholine receptor and stop the improvements and reverse the improvements back to baseline. And that is exactly what we did. So as scary as that sounds, it was somebody that had already had major improvements in voice. And even outside of that, was walking better, was moving better, was able to use his hands better. And then we put a medication on board that we knew would bind to that receptor, right, and prevent acetylcholine from properly binding. And we watched over the course of about an hour that person go back to baseline as if we'd never treated. And then the following day, we re-regulated that pathway and we regained those benefits. Okay, so we know the pathways that we're looking at. Separate from that, with Sterling, what we saw was massive improvements. And so you guys can kind of take a look at that video, the ability to stand and jump out of a chair and do those kinds of things, but short lasting. Okay, the distinction between his improvements, he continues to have improvements, but not the same as the first night. The difference between him and everybody else that has had major improvements and continues to have those improvements, the length of time that we had treated with IV approaches prior to any of the technology. So in other words, it's as if we don't have enough mitochondria and healthy astrocytes, and then we just try and correct pathways, we don't get there. So, or we can't keep the benefits in the way that we'd like. It's the reason that we normally do a 2-week for an astrocyte protocol. For me, I prefer a 3-week. And also, because I know I'm going to get this call, which is, what are you guys using? It's different for every person. Okay, so I don't say that to be difficult. I recognize why we need a uniform approach so more people can have access to treatments, and these treatments can be offered in centers worldwide. The challenge, remember, what you have, I believe it's a symptom and not a disease. The thing that's working for somebody else to improve astrocyte function is not going to be the same from one person to the next. Now, what I would tell you is we are getting better at a classification system to understand which protocols work best for which clinical symptoms. And so the astrocyte protocol is not the same from one person to the next. What we do know is without those treatments, without that medication, we can't build enough astrocytes. And then when we pair the technology, so whether it is a transcranial stimulation in the motor cortex, or whether it is a modified block at the vagus nerve, we know that once those things kind of wear off, once a block wears off, so will the benefits. All right, so it really is the combination of things. As far as adding repair along with pathogen eradication, remember the place I used to be. I was super focused on, excuse me, seeing the infection, going after the infection. And it worked for a number of people. as far as slowing down progression or even stopping progression. And the question was, how do we go from there to actually regaining function? And so, although 4 people regained function, the question was for everybody else, what's the holdup? And so it became very clear this is not just about getting rid of infections. The infections have already caused very extensive damage, scarring, and damage throughout the central nervous system. And so the real question is, what do we want to do as far as repair? So a major switch that we made in December, I've been working on a new stem cell combination for quite some time. And so we've been using cells since 2019. We typically use them intrathecally, meaning the small injection at the base of the spine. For motor neuron disease, that's always been considered the gold standard, at least in clinical trials. So we like to do the same. The question is, do we really have the right kind of cells to regenerate? So what I would tell you, all those cells have FDA oversight, but are not FDA approved for ALS. What is true, there are countless papers showing the benefits of the use of stem cells, especially intrathecally in people that have motor neuron disease. It comes down to the timing of things. And so the goal is, are we focused on repair, not just pathogen eradication? And so again, just kind of talking about the timing, we're looking at a handful of different things. So thing number one, we're not going to get anywhere unless we have figured out the root cause. So our starting point over here, run a handful of tests to figure out what kind of pathogens, what kind of chemicals, what are the most likely causes of the motor neuron damage. I recognize that everybody would love to skip that point. One, it's time consuming, and two, it can be costly. It doesn't change the fact that if we don't know what we're treating, then we don't know what we're treating, right? And so just kind of throwing darts at a wall to see what's going to stick, I don't think it's going to work in a disease like this. So step one for us is getting clear. And so if you're somebody that's a new patient considering coming here, that's the first step. If you're somebody that's already been here, you know that that's kind of the first thing that we do. Then we're going to be looking to correct those problems, different kinds of modalities to do it, depending on where the real problem is. Is it a very specific group of chemicals? Fluorinated compounds are specifically toxic, especially toxic to astrocytes. So are we trying to reduce halide toxicity? Are we trying to reduce infections in the microglial cells? What the heck are we trying to do? So that's our starting point. But then as soon as we start working with that, we're simultaneously working to then improve the glial cells so they can perform for the motor neurons. And shortly after that, we're looking to put on kind of a physical technology to start crafting pathways, right? So whether it's transcranial, so with electrical stimulation, impacting the overexcitatory involvement in the areas of the brain and the excitotoxicity, or like a vagus nerve involved control switch. If we do that, but we don't have control over the infections are going to keep damaging the pathway. So you kind of get a sense of pathogen eradication in and to itself is not adequate. If you're just out there just treating Lyme, for example, chances are that's not going to be enough. You're still going to need a correction strategy. And for us, stem cells and autophagy modulators have largely improved our outcomes. So then that is the starting point. Evaluation, if there are infections, that we're going to be treating them. How do we know what we're doing? So this is what I had mentioned already. Although there are not labs that I'm aware of that can really look at the changes in serotonin and acetylcholine real time, and there aren't good images. Most images are too gross, meaning they're too big of a picture. MRIs, we can't see it. Functional MRIs, we can't see it. We looked at the idea of using other technologies, EEGs, SPECT scans. We can't see it over there. We looked at blood tests. We looked at cerebral spinal fluid tests. We just can't get there. And so our way of doing it, again, we can put a medication on, bind a receptor and see exactly what happens, and then we know. So we've already gone through kind of the process to get an understanding of what we think are the real pathways. Okay, so the transcranial side of things, again, my background, stimulation in the brain, I did it for quite some time as far as instructing on that type of thing. And again, the neuroanatomy behind it. So I've been looking at it, but I did not find it to be a successful strategy in and unto itself. Going back to the idea of, can you use a monotherapy? So then you start stimulating the motor cortex or the cerebellar tracts. It still doesn't change the fact that if the underlying problem is serotonergic to acetylcholine, if that balance is off, or if there's still infections causing ongoing damage, then in my estimation, just providing stimulation to the motor cortex in and to itself is not going to be enough. Okay, however, we started with the first person this week. I went in to see him just before coming to do this call. He has totally lost speech, meaning he can still make sounds, but up until now, you cannot understand them. And today, let me think about what he just said to me. He said something like, goodness, I don't remember. He said something like, "That's a good idea." It was like a group of words. It was like 2 or 3 words, and I understood them very clearly. And so that wasn't just transcranial. It was transcranial plus the vagus nerve component, plus building mitochondria and astrocytes, or that's what we think that we're doing. It was that combination. So we did transcranial on Tuesday and again on Wednesday. Today, voice is better than it has been. I have not been able to understand anything up until now. Neck strength is better. Arm strength is better. And we've already seen in a lot of other folks improvement in the use of facial muscles, ability to smile. And the reason that becomes important, ability to chew, ability to swallow. For the person that's in my office, good or bad, so has a judgment-free zone. He's trying to get back to eating a Big Mac. So with a feeding tube, right? He's already progressed to that point. And now the question is, could we get swallowing back to a place? Well, as of today, he is able to move facial muscles, smile, move eyebrows, move face around. He looks to have better control over the masseter, which of course is critical for chewing and even swallowing. And so we'll see what comes next. We did not start with transcranial. So again, I don't think it's going to work like that. Instead, we've already gone through kind of the process as I've described it, looking at the other pieces. And so now we're in a point where we can put something on board, correct the electricity. And so the thing is to inhibit the excitatory, the brain being an inhibitory organ. So unlike a car where you put the gas on and accelerate, the brain is largely inhibitory, as if you start your car and it's already going to go 100 miles an hour. So you tap the brake to slow it down to your speed, right? So accelerated or excitatory is you put the gas on to go faster and faster and faster. And inhibitory is the gas is already on, it's already out of control, going super fast. You turn your car on and it's going at warp speed. But you can immediately put the brakes on and control it. So the brain is inhibitory. So the idea of transcranial offering a way to reduce excitotoxicity or overexcitatory stimulation in that part of the brain. You're looking at the ALS Today article that was based on the November findings that actually looked at this. And the only reason to use this one rather than the actual article, because you're seeing their summary, right? Small trial extended patient survival by 71%. Now, again, with that in mind, I don't think that's true. I don't think there's a monotherapy. I don't think anybody's going to go for transcranial stimulation and get the same kinds of improvements that we're seeing in the person that's here. Instead, it really was the process of kind of going through the whole thing until we got there. Pre and post treatment protocols. Just know we normally like to start a peptide protocol. What we're trying to do is clean up the mitochondria before you get here. We don't have to, but it's always my preference. And so there's a couple of peptides that are mitochondrial signalers. They are naturally made in the mitochondria. We started off with the conversation that mitochondria in people that have motor neuron involvement are not working properly. And so if we can, even before you get here, start putting things on board, the mitochondrial peptides, the things that healthy mitochondria make in order to improve that mitochondrial function, we will look to do it. As far as home testing, we'll look to do the same. We'll look to get information on infections, chemical exposures, fungal exposures, genetics, nutritional status, immune function. We'll look to get a lot of those things. Oftentimes we can do some of them at home. And so if you are new and thinking about coming over here, we'll always start with a Zoom call. The reason to get an understanding of the most likely root causes of your motor neuron involvement. And then from that, determine what tests are going to be most useful and then work from there. The website is bodyscience.life. And so I know we could have gotten a .com extension. That would have been easier. When I was thinking through it at the beginning, I mean, it does really feel like this is a life altering disease, and the things that we treat in neurodegeneration are. So at the website, bodyscience.life, there is a link for new patient registration, or if you are a patient that was coming here previously, the registration link is at the very top. And then what would happen is you would fill out your intake form, schedule your time. We'll probably get on the phone together for a Zoom call. It takes about an hour. The goal of that call is to come up with a strategy, right? To get really clear on what we think the root causes are, what are your exposures professionally, geographically, what's your family history, what are the most likely reasons that you have motor neuron damage, and then we will run tests to confirm or disprove that hypothesis, and then put a protocol around that. Okay, not only am I way over a half hour. Okay, I'm horrible at staying on time. I'm at an hour, so let me do this. I'm going to take us off of screen share so I can actually see questions. I'll put my glasses on so I can read questions, and then let me get a sense of whatever you guys want to talk about. Let's take maybe 15 minutes and go through everything. So, okay, let me just say, oh, it is Craig. Okay, so Craig is the person that is in-house right now. Hey, Craig, thanks for putting comments up. I wasn't sure if you were okay with us talking about you specifically for transcranial. You think it's important for people to know they are monitored pretty much on a daily basis, and that treatment could change on a whim depending on improvements, reactions to the treatment, the day or 2 days before, to ensure best case scenario treatment. Okay, so that is a true fact. We're not trying to plug you into some type of pre-existing protocol. Remember, I mean, really, if we had a protocol, I would have put it out there. As a center, we very, very desperately want people better, and we could not be more committed if we tried. If there was a protocol, we would so put it out there. The reason that I do these kinds of webinars and describe what we're doing is because I want it clear how we're doing things. The reason I'm explaining serotonin and acetylcholine, to give you an example, is so everybody else doesn't have to bang their head up against the wall like I did for 3, 4, 5, 6 months trying to move serotonin. Instead, it's me saying, hey, before you spend the time that I've already spent, it's acetylcholine. Let me just tell you what's going on. And so there isn't a protocol. And Craig, I completely agree to your point. When people come on in, we have an idea of what we're going to do. And then how you respond each day is what's going to change that. And on the transcranial day, as an example, what we did was we changed amplitude twice. And then on day 1 and on day number 2, we kept that amplitude. What we will likely do now, next time around, is refine the field of current. So always you're going to have an anode, cathode, so a positive and a negative. If you do not refine the current, then you have kind of like an oval shape of current going through those two, the anode and cathode, and it's equivalent in all places. And so refining it means the back, meaning the posterior, so the motor cortex area, if that's the place that you want to target, but your other point is over here, you can stack electrodes to make a shape of a current that's more teardrop or heavier posteriorly. Or you can change the field by making it like a really tight circle that's right over there. So using that as an example, we're changing stuff all the time. And the reason is, how do you respond to something? Until we can see your response, we are not sure what we're going to modify. So when you come in, we already have an idea. We've already put a plan together. We watch how that plan shows up. And then whether we're talking about left side, right side for vagus nerve, whether we're talking about the field shape and size for transcranial stimulation, whether we're talking about medication that's going in an IV and the dosing or the stacking, it's changing here all the time. So yeah, Craig, I agree. It's not really a protocol driven situation. It is a, how are you responding? Our goal is your goal. You can't just keep getting worse. Right. And so we're going to have to figure out how to get control over this thing. And so we are clinically looking for symptoms that are improving. And I'm not talking about tiny improvements. I'm not talking about using a spirometer to see if your forced vital capacity has gone up from 40 to 41. And meanwhile, you can't really tell, and it's not really changing your breathing status. We should not need to be able to see, can we get one tiny percent increase in strength with muscle contractions or contractile force? Either you're better or you're not. Either, Craig, in your case, where today you say something and I can understand it where I have not been able to this whole time, or you can't. And so until we get what we're looking for, which is outcomes, we will keep modifying the approach. And I would tell you, everybody that's on here probably knows it already, but this is a very imperfect science. For the folks that come and we can't quite figure it out, look, just know we are trying like crazy and we will continue to try. And so when I think about a handful of folks that I had, they had control over progression, but I didn't know how to get them better. And I told two people come to my mind a while ago, hey, look, I don't know how to get from where we are to the next place. I'll call you when I do. And then I called a handful of months ago to say, look, I have changed where we are. It's not just about trying to treat infections or an SOT-based strategy, but now I think I have the thing that gets us to the next level. And sure enough, when those folks came in, one that I'm still waiting on to see improvement, but the others have in fact improved. So if you are out there and we just haven't found the control switch yet, keep in mind the reason that we're constantly adding new approaches is to be able to get better outcomes in more and more people and to do it faster. Okay, so Linda, let me just read it. We've just scheduled our first trip in 3 weeks. We would like to target pathogens as well as do the astrocyte and other protocols, asking due to recent fast progression. Okay, so Linda, I'm not sure what the actual question is. You're asking about, I assume, whether or not we would do astrocyte protocol and if that's the approach we would take, meaning going after pathogens because of recent fast progression. Whether somebody has fast progression or slow progression, our steps are still going to be the same. I recognize why this whole thing is a lot scarier when progression is rapid. If I had my option, we would treat at the very beginning. I recognize why it's impractical. Getting to Miami, the cost of all this medication, I realize why it's impractical. Doesn't change the fact that if I had my option, we would get started at the very first symptom. When we get started, in my estimation, does not change what's ultimately going to happen. The folks that you're seeing that are getting improvement, they've had symptoms. So Sterling, I think about the fact that, symptoms starting 2018, 2019, I think about Greg with all of his improvements, and he's like 3-4 years in. Cindy, kind of the same thing. Craig, I think about you. So it's not to say that we can't get improvements at any point. What I would say, here's our hardest: when somebody waits until they're really aggressively progressing. So the example I would give you is if you're progressing really slowly, if this is your speed of progression, and we're trying to get improvement in motor function, it's a lot easier to go from static or stable to improvements. And then by comparison, let's say somebody is worsening and their speed is like this, right? Getting them from here to stable is very different than somebody progressing at this speed. So at any time you can come. And I'm glad that you are coming because, Laura, I don't understand. There wouldn't be an alternative, right? So you come because you come. But for everybody else, I would tell you, please try and come before things get really out of hand. Laura, for sure, we go down exactly what you're describing as far as a road, which is let's figure out root cause. Let's confirm that we know root cause. If we think that we're looking at an infection, let's look at the antibodies, but then let's also look at antibodies in the central nervous system to confirm it. And let's look at antigen loads to really see that pathogen, know that we don't just have some kind of immune confusion or cross-reactivity, so a sensitivity, specificity lab problem. Let's really know what the heck we're doing, and then let's go after it. As far as astrocytes, we will very definitely start with that. I think about the call that we had and the rationale for astrocytes. For some other people, it may be a microglial focused approach. For some others, it may be an immune focused approach. And for others, it may be oligodendrocyte or combinations of them. And then let's see, Maria, can cranial stimulation, oh, hey, Maria, how are you? Can cranial stimulation restore movement in hip flexors, leg, foot movement? So here's the thing. I don't think anybody knows. And the whole process is so early on. I would like to tell you that we could somehow select a certain area, right? So we can select the corticospinal tracts and we can select the motor cortex, right? So from transcranial, we can pick areas of the brain that we want to stimulate. And I use that word kind of cautiously, because remember, we're actually trying to get inhibition. So we're not really stimulating to get stimulation. We're trying to stop overstimulation. Maria, I don't know that this is in a place where we could target hip flexors as an example. I don't think it works like that. But what's interesting, just thinking about Sterling and the video that he did, and I'll tell you, we're seeing this across the board now. Here's how people are describing it. It's like a switch that switches on. Right. So that's almost verbatim what I keep hearing. It's not a location. It's like all the locations. This is not what I thought it would look like. Okay, in the folks that I've worked with that have gotten better before. So before I really came up with an approach of rebuilding. So not just pathogen eradication and reduction of chemical burdens, but instead pairing it with an approach to restore damaged pathways and damaged tissues. Before that, what it looked like was an area that would improve and over kind of a period of time. And that period of time was commonly like a 6 to 12 month period of time. So it was an area, gosh, my right hand is getting better. I have more function. And then next month I have even more function. And then, okay, now maybe it's my arm. What we're seeing now looks very different. So when I think about the folks, and again, the way that it's being described, people keep saying the same thing. It's like the motor neurons were trapped under a cage. It's like the cage has lifted and now the motor neurons are firing. And it's not one area. It's like just function. It's functional gain. That's not what I thought. That's not how I saw this disease. I saw this disease affecting things in a localized fashion. The right arm is the right arm, different than the left arm. But that, again, when you watch the videos and you see people that are describing it, when I think about Greg and starting astrocyte protocol with the intention of improving his voice and just trying to ensure that he didn't lose his voice. And so now, I mean, his voice is really clear and really loud and really fast, but it wasn't, of course, back in November. So what I was trying to do was get voice. And what I thought I would control along with that, swallowing and breathing, right? For the reasons that we talked about earlier, that they're linked, and mood. When he all of a sudden started getting fine motor coordination back in his hands, that for me was surprising. When he started walking better, he described the last time he came down to Miami, he left the plane, he walked by himself down to baggage claim, and then he lifted the bag up off of the carousel himself. Right, so you're talking about a whole body that seems to be just getting improvement. And unlike before, so people would come and you'd see improvement while we were treating for the folks that did improve, right? I'm not trying to suggest everybody gets benefit, but a majority do. And then they would go home. And our goal when somebody went home, we just hope that they don't get any worse. And we put home protocols on board to try and stabilize any improvements that were found in clinic. This is different. This is like we do something and then people go home and they call a couple weeks later and they're like, okay, here's what I could do when I was there. And here's what I could do now, which is even bigger and better, right? So what I can tell you, Maria, I know why for you and Michael, this whole thing becomes really important to get control over. I do not think, to your question, can we restore movement in hip flexor, leg, foot? I don't think it's going to be targeted like that. But I do think we are seeing results in more people and results faster. So that's what we're looking for. Okay, Janet. Hey, Janet. You've talked to several people about the brain stimulation with excitement. For those of us that are clueless, how is it different than electric shock therapy? Okay, so I'm not sure that it is. Meaning, when you put an electrical stimulation in the brain, I mean, it's a shock, right? And so the difference, you are modulating a wave. And so anytime that you're doing something electrical, when you're using an electrical device, you're talking about a square wave. So the brain has a sine wave function. The wave generators are square wave pulse. So kind of have that in mind, that they're not the same kind of wave. You can modulate it, meaning you can change the height. So that's the amplitude. You can change the frequency and the rate. The rate is how many of these, in this case, these are going through over a length of time. And the frequency, how wide are they? And the amplitude, how high are they? And so the kind of current, the way that you shape the current, and most importantly, the target of the current is what makes the big difference. So you think about electroconvulsive therapy, you're putting it over here and you're just kind of zapping the brain. We're not trying to do that. And in the trials, that's not what's being done. Instead, you are looking at the motor cortex. So you're looking at a very specific area because it's the area that is involved in motor neuron disease. You're looking at the corticospinal tracts and the motor cortex, and you're looking at the kind of current that is wildly different, both in the strength of the wave, meaning the amplitude or the height of the wave, in the frequency or the length of this wave, and the rate, how many are going through in a given length of time, milliseconds. So the kind of power and the location for that power is what makes us very different. So what I would tell you is, there's a huge difference between plugging my oven into a 220 volt. For everybody that's international, I know that the voltage is different, but in the States, there's a huge difference between plugging my oven into 220 volts or plugging my, I don't know, hair dryer into the outlet in my bathroom, which is 110 volts. If I try and plug my hair dryer into a 220, I would blow it. Right? I would, probably blow a fuse, and I'd destroy my hair dryer. Right. And at the same time, I can't just take my oven 220 volts, which is required. So again, like kind of the strength of the wave, the amplitude, the current. I can't take that and plug it into my 110. This is kind of the same. Just because both are electrical currents, it doesn't make them interchangeable. So the targets are different. The current itself is different. The shape and the modulation of it are very different. I'm hoping that helped. And then, Maria, yeah, for sure. Janet, to your point, is interesting. Yeah, here's the thing. Going back to, can we just rely on medications? Well, maybe, but certainly it has not been successful up until now, right? So the idea of just adding medications has not worked. And so the question is, could we then just do technology? Probably not. Could we pair up the combination? And it's not medication or technologies. It is, can we repair the damage in the cell? And the first question is, what's causing the damage? And the second question, which I was so off base on, which is the cell that we're targeting? Is it the motor neuron or is it the glial cells? And what we know now is, at least from our vantage point, it is the glial cells. Okay, so do we have the right cause, the thing that damaged it to begin with? Remember, I know you guys know this, you were all perfectly healthy before you weren't. Right? So meaning something got in and damaged the cell. what we're going to have to do is get back in and reverse that damage, reduce the inflammation in order to get back to the cell functioning in the way that it did before it was inefficient and leading to motor neuron disruption. Okay, so what's causing the problem? How do we want to reverse that damage? Okay, once we know that, then what kind of medications could we use to help repair the cell, or again, build more mitochondria, or correct endoplasmic reticular dysfunction, or whatever we're trying to do over there, or re-signal an immune system to become more sensitive and specific to existing infections, whatever we're trying to do. Okay, and then the question is, so we've done that, but we're still stuck with pathways that need to be rerouted and overall damage in that area. Going back to herpes simplex 2, again, remember, this infection for most cases is living at the base of the spine. Doesn't change the fact that it must alter humans, the behavior of that host in order to spread. So it is going to control neurotransmitters in the brain. Just because the infection has been controlled does not mean that you have restored neurotransmitter pathways. And so that, I think, is the place where technologies, so physically interacting with the stimulation pathways in the areas like the cranial nerves, including the vagus nerve, right? And again, the acetylcholine pathways and how they're moving around, that I don't think is going to be accomplished just by medication. And so I think what we're seeing now is, again, better results across a lot more people in a much faster period of time. It really is the marriage of the medication side of things as well as the technology to physically manipulate the pathways. All right, let me see if there's any other questions. No, it looks like that's everything. Okay, I'll put a call out one more time. Guys, if there's any other questions, I'm happy to answer them for you. There was one other thing that a lot of people have been asking about. Let me just answer the question about diet that I had gotten from a lot of people before this call, and then I'll let you guys go. So I understand there's been a lot of discussion, fasting and now carnivore. Let me just tell you, I have discussed this multiple times in the past, but I'll tell you where I am. Motor neuron disease or not, meaning whether you have motor neuron involvement or you don't, the question is, what kind of diet is associated with health in humans, right? So whether you have motor neuron disease or not, you're still a human. And the question is, what diet is most associated with longevity? And I mean, the trials and the studies have been done over and over and over and over again. And Mediterranean, because of the healthy fats, looks to be the thing that creates the most longevity. Now, with that in mind, altering it to have a more keto focus to remove the grains and the dairy becomes really important. But healthy fats are super important. Remember, animal fats are saturated. So that's indisputable. Saturated fats fall into the omega-6 category. They contain arachidonic acid, and arachidonic acid is primarily pro-inflammatory. I realize it can have some anti-inflammatory properties, but primarily, especially in an inflamed individual, it becomes pro-inflammatory. If you're eating animal protein, then you are going to have the arachidonic acid pro-inflammatory component of that. The way to balance it or negate the inflammatory part is the anti-inflammatory benefits of plant-based unsaturated, so meaning mono or poly unsaturated fats. If you don't have enough mono or poly unsaturated fats in your diet and animal fats make up the majority, then indisputably you are going to have elevated omega-6 by comparison to omega-3 and 9. In the world of cardiology, that is used as a predictive marker for cardiovascular disease. From a muscle loss point of view, it is very important to have a diet that is high in protein. I like animal protein. So this is not a question of whether or not animal protein should be in the diet. It is low fat animal protein. So a filet mignon or a lean ground beef versus a ribeye or like an 80% ground beef. So you want it to be as lean as it can. White poultry, white meat versus dark meat, right? So that part becomes really important. And to have an equal balance of a plant base because it's anti-inflammatory, so mono and poly unsaturated. Remember, what's been in dispute for quite some time is whether or not carbohydrates belong in a diet. So neurons like healthy fat, muscles like protein. So the plate, from my vantage point, gets divided almost in half between plant-based, healthy, so that's mono and poly unsaturated fats, and then the other half, which should be lean animal protein, grass-fed, to reduce arachidonic acid inflammatory component. And then there should be a small part of that plate, I like about 10 to 15%, and that would be a complex carbohydrate, meaning low glycemic index, so very, very low glycemic, slow releasing sugar. And the reason, remember, cells require the process of glycolysis. They cannot turn on without a starter. The same way a car, first the starter ignites the engine, right? You go through the starter process, and then the engine goes through its process of compression and ignition. But if you don't initially start with the starter, if you don't ignite things initially, the engine is not going to work. The cell is the same. The starter for the cell is glycolysis. What the cell is running on after that, the car is running on gasoline or diesel. The cell is running primarily on fatty acid oxidation. Okay, so without any sugar or glycolysis, you are going to have a hard time getting a cell to start or having a cell go through gluconeogenesis and things like that, repair. And so it means that small part, 10 to 15%, rainbow diet, it's the place that you're going to get lots of nutrition, minerals, vitamins, seeds, nuts, and as much rainbow coloring as you can get. So study after study after study after study continues to show the benefits of a Mediterranean diet when it comes to longevity, primarily because of the healthy fats. The objective would be to remove the grains, right, and dairy, and focus instead on all the healthy fats. Motor neurons love them. All the healthy lean protein, muscles need them, and a small amount of rainbow diet, very low glycemic index carbohydrates that ensure that glycolysis, that initial startup in the cell, works properly. Okay, quickly about filgrastim. Okay, Maria, let's do 2 minutes or less. The long and short with filgrastim. So it's an interesting medication. What you're looking at is third stage trials, third phase, specifically for ALS. What we know is filgrastim is a medication that comes out of oncology. It can be used to improve the production of cells from the bone marrow. In oncology, that's usually because you've radiated the bone marrow, typically because an individual has a blood cell cancer, because the cells are being made in marrow from certain bones. You can radiate those bones and that marrow and stop those improper cells from being made. Filgrastim is a class, it's a type of medication in a class that encourages the bone marrow to work faster and produce more cells. What's interesting in the findings for ALS, separate from the ability to increase white cells so substantially, separate from that, filgrastim can increase the mobilization of the stem cells that are being made in the bone marrow and facilitate the mobilization of those cells from bone marrow into the peripheral blood supply. Okay, so we use stem cells, and the question is, would it make sense in combination with that to also use something that has already been showing benefit in motor neuron disease, can increase mobilization of stem cells, and separate from its ability to increase cell production. White cell increases from 5,000 to 30,000 in the course of a week, so very, very substantially. In addition to its ability to increase the mobilization of stem cells from the marrow into the peripheral blood supply, which is where the stem cells really can work, find damaged cells and start replacing them. But separate from that, it has been proven to be a medication that reduces neuroinflammation. And so because I had been working for the last handful of months, a little bit longer than that, to craft a better style of stem cell that was more useful in what I think. I think it's more useful in repairing the kind of damage that we're seeing in motor neuron disease. Then the next question was, could we facilitate simultaneously your own body's ability to provide stem cells or mobilize stem cells into the bloodstream? And so I was looking for that concept. I remember doing a Google search on how could we improve stem cell production in people with ALS. And then I realized it's not a stem cell production problem, it's a mobilization problem. Come to find out, filgrastim was already in clinical trials and showing that exact benefit. So that's why we looked and started pairing it up. Okay, and finally, okay, I feel like I'm going to butcher this name. Is it Bodil? I'm hoping. Finally, does this also apply to multiple sclerosis? If so, why do you only talk about ALS? So my focus is neurodegeneration. It's root cause analysis for neurologic conditions. Again, I started in neurogenetics, which is kind of the idea of what is somebody predisposed to have. And then the question was, that doesn't make sense. How do we alter that destiny? And so I got really focused on figuring out how do we make these genes less aggressive? And then why, for some people, are genes being turned on? What's the epigenetic component over there? So I moved away from neurogenetics after almost 10 years. Imagine it was kind of the study of what are people going to get? So if we all do nothing, what's going to happen to that person? And that for me feels futile. And so then I moved into neuroanatomy, neurotargeting, and localization. So finding certain structures that were controlling movement and then using stimulation to eradicate movement disorders. And still for me, it felt like, what's the root cause? Are we ever going to get to the root cause? We're just going to wait for people to get sick and then treat. And so that's when I opened my own clinic in 2009. At the time, my medical director was a neurologist, and we worked together for about 10 years. And multiple sclerosis was something I worked with a lot. I have a very large group of people that I treat with ALS. And for that reason, it commonly becomes the topic of conversation. But the number of folks that we have worked with that have had just really remarkable improvement with Alzheimer's, Parkinson's, and multiple sclerosis, Guillain-Barré is a very, very large number of people. It's just, I don't know. I guess I haven't really put a focus so much on targeting conversations around those other conditions. As far as multiple sclerosis, the autoimmune component becomes a very, very critical one, as you already know. The amount of improvement that we're seeing in people that have multiple sclerosis, so moving from relapsing, remitting, into just remitting is something that we're pretty good at. It was the MS model that for me helped me understand ALS, which I believe is also relapsing remitting. But unlike multiple sclerosis, where there may be 3 or in an untreated individual up to about 6 relapses in the course of a year, and then in between you have those episodes of remission that can last for extended periods, months at a time, or sometimes even years at a time. ALS, I think we're looking at relapsing and remitting, but the remissions are so tiny, the disease looks like it's always progressing. But when we have done the numbers, I'm not talking about an ALS functional rating score, but the actual immune components and markers of disease itself, we can see windows of what looks to be remission. And our goal actually is to extend remission into bigger and bigger periods of time. So even if there's a relapse, it's very short. So the kind of concept behind Alzheimer's, Parkinson's, ALS, MS, it's all neuro dysfunction resulting from living and non-living neurotoxins, so infections and chemicals, and an immune component where the immune system gets involved because it becomes so unhappy from these pathogens, these infections and chemicals. And so for me, with this thing results in a lot of white matter scarring kind of throughout the brain and spinal cord, MS, and has a really large autoimmune component, or whether it is more in the basal ganglia. So, specifically a subthalamic nucleus, instantia nigra. So we're talking Parkinson's, whether it's the amygdala and hippocampus. So the target of that whole thing, is Alzheimer's, or whether, it's horn cells front of the brain. So we're talking about ALS. The pathophysiology is the same. It's the geography that changes. And so, listen, if you want to talk more about MS, I love working with MS, meaning all of these for me feel good to work with and to get control over. And so if you feel like you want to talk more about MS and you want to get a crew of people together that feel like spending their hour listening to me talk ad nauseum about pathways for a disease, I would be more than happy to do it. All right. So again, it's not by design. It's just that there's a large number of people that we have worked with that have ALS that are interested in knowing the next steps that we're taking, but we have found impressive control and success in neurodegenerative diseases as a whole. Okay. All right, guys, I think that's it. Number one, because I don't see any more questions. And number two, because we've got to be out of time at this point. We're coming up to, imagine, almost 2 hours. Thank you guys for jumping on. I'm glad that we got a chance to go through things. I'll always try and answer them by email and get on Facebook, but it's almost impossible for me to spend the time. This for me is infinitely easier. So thanks for making the time and doing this. We'll go ahead and get this recording and put it up. It typically takes, to the end of this day or the following day, but I'll make sure to get it over there, and I'll try and follow up as soon as I can with any new updates. All right. So just know we are 100% here thinking about you guys all the time. All right. We will get this thing. We'll get this thing, right? We know from the very beginning of the slide, it's a symptom, not a disease. And even the most difficult experts, the ones that were so unwilling to describe this as a treatable disease, even those folks are describing the treatability. And so if ever there was a time for, just kind of changing mindset on this whole thing and looking at it differently and just finding what's the right approach for you, like your specific thing, and then just kind of working through all the steps. If ever there was a time for it, there's been so much new technology in the world of neurodegeneration over the last 5 years. It dwarfs, I think, what was the speed of technology for neurodegeneration for at least the 50 years prior. Right. So we're at a time of a lot of new development and a lot of much better understanding. It's always my hope when I do these Zooms that I can use what we're learning over here and put it out there to shortcut it for everybody else. And with that in mind, if you are somebody that's out there that thinks that you've got something that is a game changer or that's relevant, just be aware, I very definitely do not think I've got the market cornered on this. Instead, I would tell you, nobody knows what the heck they're doing in motor neuron disease. Nobody that's treating motor neuron disease knows what the heck they're doing. This is such a complicated disease. If you are out there and you think that you've got something that's worth adding into this protocol, oh, for sure, call or email me and just send it over. We will very definitely look at it and consider adding it. Okay. Until next time, guys, I'll see you. Bye.